Welcome to everybody that's joining this wonderful live and interactive webinar on Synbiotics and allergy management. My name is Dr. Roseanne Meyer. I'm a pediatric dietitian on a senior lecturer at Imperial College, and I'm also visiting professor at KU Leuven. So I want to introduce our speakers. I think you will agree we have two wonderful speakers. Excuse me. First one is Professor Harald Renz. He's world-renowned, lots of publications. He's the Director, Institute of Laboratory Medicine and Pathobiochemistry, Molecular Diagnostics at University Hospital in Gießen and Marburg, so from Germany. Professor Renz will be addressing the first topic, which is the cause and effect of an imbalance of gut microbiota in early life. Second, an equally eminent speaker is Professor Anna Novak-Bextrin. She is the director of the Pediatric Allergy and Immunology Division at the Hasenfield Children's Hospital in New York, and she's also professor in pediatrics in New York University School of Medicine. She will be addressing the topic, apologies, on Synbiotics modulate gut microbiota and strengthen immune defense in cow's milk allergic infants, implication for clinical practice. So you will see this is a very live and interactive two presentations, and of course we have the questions at the end. So now that we've done the introductions, what we're going to do, we're going to move over to our first polling question. Don't worry, you'll have plenty of time, and I'm going to read the polling question to you is, how many children with suspected or confirmed cow's milk allergy do you see in a week? That might be less than 10. It might be between 10 and 20. We might have some specialists amongst us, so it might be 20 to 30 or more than 30, where this is the mainstay of the patients that you see. You'll have a couple of further seconds to think about your answer. So how many children with suspected or confirmed cow's milk allergy do you see in a week? And you've got 4 different options. I see the results are going to come up now. The vast majority, and I know our speakers are also listening to the results, so the vast majority, that's 81% of you, see less than 10 cow's milk allergic children per week. Then only about 16%, 10 to 20, and then a very small number is between 20 and more than 30, so only 4%. So it gives us a really good idea where we're moving to. So now that we've got that background information, we're going to launch into our webinar, and please send those questions through and enjoy it.
So, hello everybody. I'd like to welcome you to this very special global webinar. This is a very unique experience also for myself. Due to the corona pandemic, we are learning a lot of new communication skills, so I hope we will do here a very educational webinar today. My name is Harald Renz. I am from Marburg, Germany, and I have a special interest in the immunopathogenesis of allergic diseases, with a particular focus on the interaction between the microbes, the immune system, and the environment. Next slide, please. So it is quite clear that the healthy gut microbiota plays a very important role in educating and training the immune system. We know that there is a very close crosstalk between the gut microbiota and immunological functions, and this is important for the understanding of the development of clinical tolerance on the one hand side, but also for the development of chronic inflammatory diseases such as allergy and asthma. Next slide, please. When it comes to the development of immune functions, or the capacity of the immune system to combat diseases, this is illustrated here on this slide, we see 2 highly vulnerable periods in life where the immune system is either not yet ready. This is referring to the left-hand side of this slide, indicating the vulnerable period of the perinatal life, or the immune system is not ready anymore to combat these pathogens, as indicated here with influenza infections. For the purpose of this talk, we are focusing on the left-hand side of this slide. We would like to understand how the immune system is being trained early on to combat these inflammatory conditions. On the next slide, we see that the gut microbiota act as a barrier function against the pathogens. This is probably one of the best known functions of the intestinal microbes, which help to keep off the pathogens which you see here in the red color. But this is only the tip of the iceberg in terms of understanding how microbes interact with the host and with the host's immune system, which is illustrated even in more detail on the next slide. Here now you see that the microbes not only physically and passively hold off the intrusion of the invasion of the intruders like the pathogens, but they do that in a very active capacity. For example, some of these microbiota produce certain antimicrobial peptides or other molecules which help to train the immune system. One of them are the short-chain fatty acids, the SFCAs indicated here on the left-hand side of this slide, and we will look into this in more detail. So the microbial communities are changing over time. On the next slide, you see that quite a number of events starting from pregnancy and running into late infancy are able to directly modify the microbial structure and the microbial patterns in a qualitative as well as quantitative fashion. It all starts already during pregnancy. During pregnancy, the placental tissue is interacting with microbial compounds, not necessarily with live microbes, but with microbial compounds. These compounds travel through the maternal bloodstream and can enter fetal circulation, and they help already prenatally to initiate early prenatal immune responses. And this then continues during the process of delivery. It makes a big difference whether the baby is born by vaginal delivery or by cesarean section. And then during early infancy, it is important how the baby is fed. Is it breast milk fed? Is it formula fed? How many antibiotic treatment courses are necessary and required to combat infectious diseases, because each of these antibiotic courses have a large impact on the composition of the microbial communities. And then in late infancy comes the introduction of solid foods, and again the microbial pattern is changing vigorously, and every infectious diseases and so on, and the ingestion of carbohydrates plays also a very important role in shaping these communities. So what this slide shows is that during this rather narrow window of opportunity, many different events have an immediate direct or indirect impact on the microbial composition. So this is a very vulnerable period, and we need to focus on this vulnerable period in order to understand how the normal microbial communities develop, and on the other side, how disturbance and dysregulation may occur. And on the next slide, you see that this dysregulation occurs actually in all allergic conditions and even beyond allergy and asthma. It is now well established that asthma, atopic eczema, food allergy, polyposis nasii, and also a completely different chronic inflammatory lung disease, COPD, is very closely associated with changes in the microbiome. Not only the microbiome in the gastrointestinal tract, but also in the upper and lower airways, in the skin, and on other mucosal surfaces. And even more importantly, on the next slide, it is indicated that this dysbiosis present in the allergic patients already occurs before the onset of the clinical disease. So dysbiosis actually precedes the disease. And this important finding is indicating that there might be actually not only an association between microbes and disease development, but that there is really a cause-effect relationship. And this cause-effect relationship we would like to better understand. The next slide illustrates the plasticity and the flexibility of changes in the stool, the gastrointestinal microbiome during the first few months of life. On the left-hand side, we see the dominance of certain bacterial communities like lactobacilli and bifidobacteria, which is due to breastfeeding, and this changes on the right-hand side dramatically with the introduction of solid foods. So I think this is a very illustrative example indicating the changes of the microbial pattern due to environmental changes, and the environmental changes studied here in this example is the mode and type of ingested foods. On the next slide, this is a little bit illustrated in a cartoon fashion. So first of all, the mode of delivery is an important factor which is priming the early stages of gastrointestinal colonization. And we know very well that babies born by the cesarean section have in the first few weeks and months in life a different type of composition in the gastrointestinal microbiome than babies born by vaginal delivery. On the next slide, you see the relevance of infants' food. As I mentioned before, as long as babies are dominantly fed with breast milk, the communities are dominated by bifidobacteria, lactobacilli, and veillonella. And when we change to solid foods, this is associated with a dramatic change in the microbial pattern towards bacteroidetes and some clostridial strains. The next slide gives another example on the vulnerability of the composition. The columns indicate, and the blue and the red color indicate the relative dominance of certain phyllae in the composition of the gastrointestinal microbiome. The blue phyllae indicate again the lactobacilli and the bifidobacteria, and the red columns indicate bacteroidetes and clostridia. And we see here with every interruption, like an episode of fever, like the use of antibiotics like aminocillin or other antibiotics, like the shift from breast milk to solid table foods. This has an immediate impact on the composition of the microbiome. So what we have learned is, when we turn to the initial importance of breast milk feeding on the next slide, what we have learned is so far that breast milk is actively involved in shaping the immune responses, particularly protecting the infants from infectious diseases. And there is a battery of mechanisms which is provided by human breast milk, helping to protect the infant from infectious diseases. If we go from left to right on the lower part of this slide, it starts with secretory IgA antibodies produced by the mother and transferred to the infants through her breast milk. This is probably one of the best studied and long known mechanisms of helping to neutralize pathogens in the baby's upper and lower gastrointestinal tract. But this is only one aspect of how breast milk protects infants in this regard. It goes on with the regulation of the gut permeability to the presence of certain antimicrobial factors in breast milk and immunoregulatory factors which help actually to promote immunological and clinical tolerance. And on the right-hand side, we have highlighted here lactoferrin as one component in breast milk, which plays a very important role in blocking the inflammatory cytokine production in the infants. On the next slide, we have summarized some examples of how microbes modulate immune functions. In this case, microbes modulate immune functions through the diet. The diet of a baby is the intermediate. And one of the best studied examples in this regard is the role of short-chain fatty acids. Short-chain fatty acids are produced by certain gut microbiota, including some strains of Clostridia and other. And these short-chain fatty acids like butyrate or acetate, they have a profound impact on the development of regulatory T cells in the intestinal mucosal immune system. And these short-chain fatty acids are produced by these bacteria from non-digestible carbohydrates. So we eat and consume non-digestible carbohydrates. Certain bacteria in our microbiome are able to use them as their own energy source, and they produce as metabolites the short-chain fatty acids. And the short-chain fatty acids help us to mount a proper tolerogenic immune response. This is one example, but there are many, many other examples discovered over the last few years how certain dietary components like proteins, phytochemicals, but also fats, alcohol and xenobiotics and many others impact in a positive or also rather negative fashion our metabolic and immune functions. With regard to these tolerogenic effects, we see more details on the next slide. Here are some prominent bacterial strains which have been discovered over the last, let's say, 10 years or so to foster anti-inflammatory pro-tolerogenic effects. I mentioned already the Clostridia clusters 1, 4A, and actually it should read 7A, which help to produce regulatory T cells, to develop regulatory T cells. We have a number of short-chain fatty acid producers, but we also have bacteria which promote IgA binding and help to colonize the mucosal niches, to protect the mucosal niches from pathogens, and many, many more examples as well. So these are candidates actually which could be used potentially with their probiotic functions. On the next slide, we have again put together and compare the healthy status with the dysbiotic status in the diseases. So as I mentioned before, in the allergic conditions, it is now well established that we find dysbiosis, and dysbiosis is defined as a quantitative as well as qualitative disturbance of the gut microbiota. And on the next slide, we have focused on cow's milk allergy as a prominent example for this. Dysbiosis and cow's milk allergy is, for instance, characterized by an increased abundance of the bacteria listed on the right-hand side of this slide, including Enterococcus faecalis, Clostridium difficile, Campylobacter, and others. And on the next hand slide, I would like to share with you a very, very important experiment in this regard. Next slide, please. On this slide, the investigators have actually taken stool samples from cow's milk allergic infants and from healthy infants, and they have put these stools stool samples into germ-free mice. Germ-free mice are completely deprived of bacterial strains on the inside and on the outside. And if we colonize these germ-free mice with the microbiota from healthy individuals, which is shown here in orange, and then subject these mice to a model of anaphylaxis, we see that these animals are completely protected from the development of anaphylaxis. So the healthy microbiota contain microbes which prevent the development of anaphylaxis. And this is in contrast to microbiota from cow's milk allergic infants. In dark blue you see the results. If we colonize these germ-free mice with microbiota from cow's milk allergic infants, these animals develop an anaphylactic immune response, very rapid temperature drop within minutes. So these are hallmark experiments actually indicating that the microbiota not only associate with disease, but that they are actually causally involved in the development of the diseases through actually changing the immunoprogram in these infants. So now the big challenge is to apply this concept, on the last slide please, to the clinics. How can we do that? How can we use now this concept in order to improve the health situation of at least infants at risk? And this leads to the concept of probiotics, prebiotics and synbiotics. Probiotics are live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. And prebiotics include these non-digestible food ingredients, and I showed you the example of short-chain fatty acids, but this is only one example of a prebiotic. So we can combine also these concepts of probiotics, the bacteria, and the prebiotics, the non-digestible foods, and develop a concept of synbiotics. All of this can be now tested in clinical studies. These concepts can be tested in clinical studies, and we are looking forward to more results in the near future to develop actually a custom-made preparation which exerts these health benefit effects in a way that we can apply this concept to a broad population. And with that, I would like to thank you very much for your attention.
I think you will all agree that was an amazing first part of this webinar. Please let those questions still come in. I see quite a couple have come through. We have got our next speaker, Professor Anna Novak, and she's going to talk about Synbiotics modulate gut microbiota and strengthening immune defense in cow's milk allergic infants, the implication for clinical practice. And enjoy this next webinar as well.
Hello, my name is Anna Novak-Bengrzyn. I am a pediatric allergist immunologist with special interest and expertise in food allergy, and it is my great pleasure to present data on and discuss how Synbiotics modulate gut microbiota and strengthen immune defense in cow's milk allergic infants, with special emphasis on implications for clinical practice. My disclosures for this presentation is that I received honorarium for the webinar from Nutricia, and that I was a recipient of the research grant and a site principal investigator for the clinical study Presta of the amino acid-based formula with Synbiotics. My learning objectives are to describe the role of gut microbiota in food allergy and to describe the effects of a hypoallergenic amino acid-based formula with Synbiotics on development of tolerance to cow's milk, as well as infections in infants and young children with cow's milk protein allergy. So breast milk is an ultimate symbiotic. So symbiotic is a combined pre and probiotics. So we refer to human milk as the gold standard in infant nutrition, And breast milk is incredibly immunologically active because it contains live bacteria, human milk oligosaccharides, as well as lactose that stimulate the gut microbiota and immune system. And live bacteria are probiotics, and oligosaccharides and lactose act as a prebiotics. However, the hypoallergenic formulas that are used currently for the management of cow's milk allergy lack these microbiota stimulating factors. So even though over the years there's big effort to emulate composition of breast milk regarding other components, this is an area that is currently being addressed more actively. So you can see that there is a small amount, so there's no bacteria, there's no human milk oligosaccharides with prebiotic effect in currently available extensively hydrolyzed as well as amino acid based formulas. And there's only a small amount of lactose in the extensively hydrolyzed formula, but not in amino acid based formula. So breast milk, in summary, is rich in factors that stimulate the gut microbiota and immune system. However, the formulas, hypoallergenic formulas, they have a very limited or complete lack of stimulation of the gut microbiota. And so this is changing. Obviously, there is a big with the recognition of the importance of the gut healthy gut microbiota and the importance of breast milk in development of the gut microbiota. There is an effort to include a symbiotic blend of pre and probiotics into the infant formula, hypoallergenic formula, to mimic the components of human milk with the intention of targeting the gut microbiota dysbiosis. So particularly, we're talking about prebiotic, the beneficial ratio. These oligosaccharides, they mimic the levels and functionality of human milk oligosaccharides. This is supported by over 30 clinical studies in infants. And prebiotics have been acknowledged by the World Allergy Organization guidelines for allergic disease prevention as having a beneficial effect on prevention of allergic diseases. The probiotic that is included in the formula is Bifidobacterium breve M16V. This is the most common bifidobacteria species in human milk, as well as in the gut of healthy breastfed infants. It was selected because of its ability to reduce allergic responses, as shown in clinical and clinical studies. And there is a long history of safe use, even in premature infants, and it is free from main food allergens. So the main message here is that this new hypoallergenic formula is enriched in pre and probiotic, so synbiotic, that works synergistically to target the gut microbiota dysbiosis. So the intention is to correct underlying disturbance in the gut microbiota. To date, there are 3 randomized clinical trials that demonstrated that synbiotics are able to rebalance the gut microbiota in infants with cow's milk allergy and bring it to closer to that of a healthy breastfed infant. So the gut microbiota of children with cow's milk allergy who are fed with the formula, hypoallergenic formula with synbiotics, shows increasing beneficial bifidobacteria and decrease in the potentially pathogenic bacteria. And this resembles, it's more in line with the gut microbiota of healthy breastfed infants. So the 3 studies that have been conducted with the formula, with amino acid-based formula with synbiotics, was done in infants with cow's milk allergy. And it showed, the readout was the changes in the microbial communities in the gut microbiota, which showed increased levels of bifidobacteria and reduced levels of Escherichia and other bacteria. In the non-IgE mediated cow's milk allergy, this formula with synbiotics showed that the microbiota was closer to that of healthy breastfed infants, and the effects were seen up to 26 weeks, and the changes were consistent with the first study that was mentioned. And finally, in the IgE-mediated cow's milk allergy, this formula, amino acid-based formula with Synbiotics, caused increase in bifidobacteria, as well as reduced levels of Escherichia and other potentially pathogenic bacteria. So I want to move on to discuss the results of the Presta study, in which I was one of the investigators. The study was designed to determine tolerance development in infants with IgE-mediated cow's milk allergy receiving amino acid-based formula with specific Synbiotics. It was a large multi-center randomized controlled clinical trial performed in centers in the in UK, Germany, Thailand, Italy, US, and I think in Singapore. So the primary objective of the study was to evaluate development of tolerance to cow's milk at 12 months of dietary management with an amino acid-based formula with Synbiotics and without Synbiotics, as measured by Milk Challenge, the most rigorous double-blind placebo-controlled food challenge in infants with IgE-mediated cow's milk allergy on control or test product. The secondary objectives were to measure the development of tolerance to cow's milk in early childhood, to evaluate maturation of the gastrointestinal immune system in IgE-mediated cow's milk allergy, to confirm that the test product is effective in the dietary management of cow's milk allergy, and to evaluate the occurrence of other non-food allergies, as well as safety achieved through adverse event monitoring. So it was a double-blind, randomized, placebo-controlled trial, which enrolled 169 infants from 0 to 13 months of age with IgE-mediated cow's milk allergy determined by oral food challenge or history of immediate reactions. And there was a large trial with 18 study sites in 6 countries. Infants were randomized 1-to-1 ratio to either Synbiotic containing amino acid formula or amino acid formula, and they were fed for 6 months with this formula. This was followed by observation period without the study product, so resuming the regular diet for additional up to 36 months. So the primary parameter was the tolerance to cow's milk on a double-blind placebo-controlled food challenge at 12 months of dietary intervention. And secondary parameters included tolerance to cow's milk on double-blind placebo-controlled food challenge after 24 months and 36 months with allergic symptoms, and measurement of skin prick tests, immune markers, as well as development of other non-food allergies. This is the primary outcome, which was tolerance development after 12 and 24 months. Overall, there was no significant difference. The overall tolerance development in both study groups was 49 at 12 months and 62% at 24 months. Looking at infants fed with Synbiotic containing amino acid formula compared to the amino acid formula without Synbiotic, there was no statistically significant difference at 12 months or 24 months. And so there's no difference in tolerance development. Regarding safety, however, there are some interesting observations that fewer infants in the test group required hospitalization due to serious infection. So infants who were fed with the Synbiotic containing amino acid based formula had significantly fewer severe infections that resulted in hospitalizations during the study. But there's no difference in other adverse events or serious adverse events. And this effect is important because it has been consistently observed through 3 randomized clinical trials with Synbiotics in infants with cow's milk allergy. And all of those trials show a reduction in infections and antibiotic usage. So in the first study, which looked at the infants with IgE-mediated cow's milk allergy, there was a significantly fewer infections as well as use of antibiotics, systemic antibiotics, specifically amoxicillin, which is the most commonly used antibiotics in younger ages. And this was statistically significant. In the second study, there were fewer ear infections and use of anti-infective, so antibiotics. And in the finally, in the Presta study, we have seen fewer infections, recurring hospitalizations in the infants fed with the formula containing Synbiotics. So this is quite exciting that there is a consistent protection from infections in those young infants. So the conclusions from the study were that about half of the children develop oral tolerance to cow's milk within 12 months. An additional 13% developed oral tolerance within 24 months. But there was no difference in oral tolerance development between children who received an amino acid-based formula with or without Synbiotics. However, children receiving amino acid-based formula with Synbiotics required fewer hospitalizations due to serious infections, which was a very interesting outcome. So what is the clinical significance of these observations? Well, we know that infants, atopic infants, have increased susceptibility to infections, and this is due to the immaturity of the immune system, which is present in all infants, even without particular atopic predisposition. There is a Th2 skewing that is present at birth, and there is a gradual maturation of the immune system over the first few years of life. And multiple studies have shown that there is delayed maturation of the Th1 immunity in infants with atopic background. This may be affected by dysbiosis of the gut, as well as the type of feeding, specifically formula feeding, which translates in development of atopy, so tendency to produce IgE antibody to innocuous antigens such as food allergens or inhalants, as well as increased infections in the first 3 years of life. And we know that in a large cohort, there was average 14 infections per infant during the first 3 years of life, and that the ear infections and respiratory tract infections were associated with the higher antibiotic use in those infants. And the most frequently used drug was amoxicillin, which is followed by penicillin. So the data suggests that there is a very high use of antibiotics in infants, and particularly in infants with atopic predisposition. This further affects the gut microbiota and contributes to dysbiosis and ongoing inflammation. So I can share with you a typical clinical scenario of the patient that I see in my clinic. It's Bobby, who was born at full term without complications. And Bobby was never breastfed. He was always formula fed. And at 6 weeks, he developed atopic dermatitis. He had an itchy and oozy rash. And he wasn't doing well. So he wasn't gaining weight. His rash became more severe. He was diagnosed with cow's milk allergy at 4 months and was switched to a hypoallergenic, extensively hydrolyzed formula, but ultimately ended up on an amino acid formula due to ongoing symptoms and poor weight gain. Between ages 6 to 12 months, Bobby had 3 episodes of otitis media, all treated with antibiotics with amoxicillin, until the ear tubes were placed at 13 months with subsequent improvement on decreasing the frequency of the infections. He also had 1 episode of wheezing at the age of 15 months. And Bobby's parents were now at this age 15 months are asking about probiotic supplementation. So there is a big interest, and obviously, by the time that Bobby is 15 months, it seems like we have missed this very important window of opportunity to improve his chances to reduce the risk of developing allergic diseases. But also, this case shows that infections are very, very common. Upper respiratory infections, otitis media, are very, very common in infants with atopic infants, and sort of contribute to this vicious cycle of dysbiosis, causing impaired development of the maturation of the immunity, and then increased susceptibility to infections, and receiving more antibiotics, and so on. It also, this example or this case scenario suggests that early early intervention to improve Bobby's chances to establish normal gut flora would be very beneficial. So in summary, new generation of hypoallergenic infant formula with Synbiotics replicate the immunomodulatory effects of breast milk, which is the gold standard in infant nutrition. Amino acid-based formula with Synbiotics, so pre and probiotics, promotes colonization of the gut, of the infant gut with beneficial bacterial communities, which represent resemble the bacterial communities seen in healthy infants fed with breast milk. And furthermore, this formula with Synbiotics has a consistent, as seen in 3 clinical trials, protective effect from infections in early life. This effect is of special relevance for atopic infants who are born with predisposition to develop frequent infections due to the immaturity of the Th1 responses. And I want to thank all of the study sites and steering committee for the Presta study as listed in this busy slide, as well as Dana Nutricia Research for supporting this very interesting study. Thank you.
Thank you to both speakers. I think everybody would agree that these were 2 wonderful sessions, and we're waiting just to get both of them live for our live Q&A sessions. Thank you for everybody sending in your questions. First of all, Anna and Harold, amazing. Thank you very much. Extremely informative. You'd be happy to know we already have 25 questions outside of the questions that have been sent in. So what I'm going to do is I'm going to start off with Harold with a really nice overview question, and that is in regards to the supplementation or the addition of pre-pro or Synbiotics. Are there specific guidelines in regards to dosages that you'd be using for children? Or, for example, if it's added to a feed, is it added because of specific dosages of what's known?
Yeah, I mean, this is of course a very important question. And regarding the optimal dosage, I think we have some initial information, but it is required to do more clinical studies, I think. I mean, there is clearly a dose-response relationship in terms of the immune effects, in terms of the anti-inflammatory effects, but also in terms of the effects Anna was referring to with regard to preventing infectious diseases or to reduce the frequency of infectious diseases. So I think we are at a starting point to establish a dose-effect relationship, but more clinical studies are needed to really confirm the optimal dose. So what we have today in terms of the available brands is sufficient to show a very good clinical response. Maybe Anna, you would like to add something to this.
No, I think you covered it very nicely. There are in the dosages in the formula, they're in an just the appropriate form and the dosage, and they're meant to be fed to those infants. So the intake is really determined by the age, and the other foods that are in the diet. So it sort of balances itself out.
I totally agree.
Yeah.
I don't go, I just pick a formula that has got it in and then say, okay, based on the nutrients, how much do you need? And then it kind of fits, it kind of all falls into place.
Yeah.
Right.
So,
Right.
Anna, I've got a question for you, and I think it's a really fair enough question. So, of course, both of you highlighted Synbiotics as a combination of pre and probiotics, and Synbiotics are not milk-derived, but many of the probiotics are milk-derived. So the question here is, isn't there a concern, therefore, for adding this blend, which have a probiotic, that there's actually milk residue in there?
So that's a great question, actually. It's a very important one, but the probiotics that are being used in the hypoallergenic formulas are absolutely safe. So they are, even if they're obtained cultures, they have been purified, they have been cleaned up. And just as a side comment, all of our hypoallergenic formulas, including amino acid formulas, are based on the cow's milk protein. So that's like the best proof that it is possible during the process of manufacturing to maintain purity and remove all of the residuals. So, but if you're looking at the products that are available on the market, the supplements, many of them actually are contaminated with milk or other food products. So that's obviously, it's something to be aware of when you are recommending or using them for children or patients with food allergy.
Yeah. So,
Yep.
and I think I was going to use a different kind of track of asking, but you've mentioned safety. Now, I think the question of safety comes up a lot. And Harald, I'm going to start with you. So one of the questions was in particular about immunocompromised patients. Would you use a symbiotic, or let's say probiotic, would you use that in an immunocompromised? And I think what is also important that we define what is immunocompromised. I think that's an important. So if I start with you and then I'll move to Anna.
That is, Roseanne, actually the question, how do we define immunocompromised infants? I would say, I mean, to start with the worst, if you have a baby with a primary immunodeficiency disease on the T cell and the B cell level, I would not use live microbes for any type of intervention, prevention, or treatment, to be really on the safe side, because the concern is that some of these live bacteria transfer into the bloodstream, and then you develop kind of a septicemic condition. But otherwise, if we say, look, an atopic infant is also kind of immunocompromised because we have a higher frequency of respiratory infections or even gut infections, then in that particular case, we have a situation where actually the application of probiotics is beneficial, and we can really rebalance this immune situation where, and Anna, I think you made a very, very important point today, and that is, I mean, you made many important points today, but one particular important point, which I remember, and that is the delayed maturation of Th1 immunity in our atopic infants. And this is kind of an immunocompromised situation, because if we have this delayed maturation, these infants are at higher risk for bacterial infections, viral infections, also fungal infections. We know that from atopic dermatitis, for instance, and here probiotics or symbiotics really help.
Yeah, that's perfect.
Anna, do you have anything to answer to add to that?
No, just to, thank Harald for, explaining it so nicely. And I totally agree, 100%.
I think something, we did not have the question this time, but I think just as a dietitian, I want to bring it out. We had in previous sessions about preterm infants, and just to bring out this amino acid feed has not been developed. So it's for preterm infant from a nutritional perspective. So we would not be suggesting that they be used. So just within that kind of spectrum, when you use it and when not. Of course, for preterm infant, there are studies for NEC on probiotics itself. So I think from that, we now moving into some of the very specific questions. Harald, there's only one person that can answer this. Is about the question about your germ-free mice study. Exactly, because you presented that, so it's your question. And the question is very specific and saying, does it only show prevention of IgE-mediated cow's milk allergy, or also non-IgE-mediated cow's milk allergy?
Yeah, thank you, Roseanne. I mean, the germ-free mice is a wonderful model. Why? Because the germ-free mice is completely deprived of any microbes, not only on the skin, but also in the lung and also in the gut. So you can really use this model for manipulations, for experimental manipulation. And that's what it is. It is an experimental model where we now can throw in certain bacteria or combinations, or we can reconstitute these germ-free mice with stool samples from humans and also from other animals. And what has been shown by using this experimental model, number one, you can prevent, if you do it appropriately, you can prevent asthma, experimental asthma, you can prevent eczema, you can prevent IgE-mediated conditions, and you can prevent also non-IgE mediated conditions like cow's milk allergy and also anaphylaxis. So it has a broad concept, but now the real challenge is to transfer these data from the mouse to the human.
And of course, fantastic answer. I'm going to ask Anna, you're going to get your own question now. And it's down the same line, because we have the question again and saying, are there studies on Synbiotics? Because your study very much focused on IgE-mediated cow's milk allergy. Are you also aware of using the same kind of blend for non-IgE-mediated cow's milk allergy?
Absolutely. I mean, there is a science study, and the follow-up studies were done in infants with the non-IgE-mediated food allergy. And I would, hypothesize that if that probably it's even more important for the non-IG, or has the higher potential to correct underlying problem, because it's sort of, intuitively we think that the problem is really related to the gut, and those infants have, a lot of evidence of dysbiosis. So if you could correct that, and they don't have sort of systemic tendency to produce IgE, you should be able to correct it. And in fact, you do. And in the science studies, very well, I mean, there was the change in the profile gut microbiota, and so definitely the non-IG is also a great target for those interventions.
Absolutely. And we were part of the Centers for the Non-IgE mediated allergy, and just some practical tips, because we found initially when you started a bit of extra flatus, because they often have a little bit more temperamental, dysbiosis of the gut. So that always settles. So once you started, that always settles. So I think in regards to the studies itself, I wanted to also ask you, there's a very interesting question that has come through. I think it's difficult to answer, but I think from a hypothetical perspective, I love it, is whether you think that the use of Synbiotics, even with children at the age of 8 to 9 years of age that still have a cow's milk allergy, would you, we've really focused to this window of opportunity, but would you still believe, and I'm asking both of you, that it would make a difference at 8 or 9 years of age?
That's a good one. I mean, if we're talking about the opinions and beliefs, I would definitely try if I had a patient. And in fact, I do recommend it occasionally for patients, but there's no evidence to really, issue a guideline or wide sweeping recommendation. We really need more studies to make it as a standard of care. Yeah, and I don't know if Harald has a different
what do you think,
take
Harald?
on that.
No, I mean, you think you are referring to 8 and 9 year old children to treat them at that age, or
yeah, that's the question seems to be if it's still worth it at 8 to 9 age.
Yeah, it's always worth it. I mean, because if we balance the risk and the benefit, I mean, it's very clear there's more benefit potential.
Potential benefit.
And I think that's an important message, is that that harm outside of, Harald, you mentioned those really very severely immunocompromised patients, but for the population with cow's milk allergy, these strains are they are studied for safety. So I think there's no harm that can be shown. Harald, now I'm moving back to you. There are lots of questions have come down to the whole cesarean section, and I'm going to first break it up and saying, first question, is there a difference between C-section and vaginal birth?
Yeah, Yeah, there is a difference. I mean, with regard to the composition of the microbiome later on, yes, there is a profound difference, but the difference levels out over time. I think this is also an important message. So the difference is most significant in the first few months after birth, and when it levels out. But these first few months after birth are so important in terms of immunoeducation.
Mm-hmm.
So it's not something we have to overlook, or we can overlook. We really have to focus on this period, number one. Number two, although there are some dominant species which make the difference between vaginally born and cesarean born babies, there's lots of heterogeneity in terms of the composition from baby to baby. So with regard to the inter-individual heterogeneity. And that makes it so difficult when it comes to the interpretation of the studies. Also, there are study variations from one study to the other. That doesn't say that one study is right, the other is wrong. It just shows us that the microbiome is so complex. And it requires so much more research in order to understand really the contribution of each of these different factors on this immune metabolic function.
So the same question, within the same question, there was another question saying, so if we are saying there is a difference, then is there a place to say, okay, this was a child that was born by C-section, they will get a symbiotic, or if they're breastfed, is that sufficient to kind of do a reset? Or would you say, actually, it doesn't matter, breastfed or formula fed, you need a symbiotic blend, for example, to reset that kind of environment?
Well, symbiotic is certainly better than probiotic alone. I mean, as Anna also showed very nicely, I mean, what we try to do is to get as closely as possible to the natural composition of breast milk. Breast milk is the gold standard. And with all our formula work, we try to get as close as possible. We are not there yet, but at least the concept of prey plus probiotic, the symbiotic concept, gets us a big step forward in terms of using only prebiotic or only, I mean, the milk formula without any immunomodulatory component.
And Anna, there were quite a lot of questions. I mean, Harald highlighted in his presentation this window of opportunity, but there was, I think this is from a clinical perspective, a question I get a lot is, what is your window of opportunity in terms of your cow's milk allergic infant? So you've got a child in front of you, and at what stage do you say, okay, now I will start you on Synbiotics now, and this is the end, then I'm stopping. and that is tick, you've had the benefit. Or is there a situation like that?
I would stop if the baby doesn't like the symbiotic. No, seriously, we don't know that. Is it better to continue maybe in a longer run, or is it only something for a shorter period of time? I would extend the period of application as long as possible.
So what do you think, Anna? Because I mean, these are the type of questions I'm sure you get. I get them every day.
Yeah, I think that I agree with Harald in principle. I think what we really need, we need studies that show us, you know, what are the proper doses and you know, how long we should be using it. Because once the infants start having, you know, more foods in the diet and there's more fiber in the diet and there's more diet diversity, maybe the role of symbiotics is going to be, you know, sort of less pronounced. And you mentioned in your previous answer, right, like that this effect of C-section sort of evens out. And I'm thinking maybe it's because, you know, babies are starting to eat solid foods and it's, you know, that's how they acquire, you know, develop new bacteria. And another thing, you know, another comment I would say is that, you know, we talk about and absolutely, you know, breast milk is the gold standard of infant nutrition and we should emulate it as much as possible. But breast milk from different women has different qualities. It has different composition. It has different, different HMOs, human milk oligosaccharides. It has different sort of microbiota because breast milk is not sterile, and it has also different cytokine profiles. So I think that it's really tricky because, a breastfed baby from one mother is getting different breast milk than, from, let's say, atopic mother who is a non-secretor for certain human milk oligosaccharides. So it is so complex that we're just scratching the surface of it. But it's exciting that there's so much interest in the
absolutely. And I think you both gave a very academic answer. I'm going to give you a very simple answer to this. The reality is we all work in a very different healthcare systems. And the reality is a lot of times these formulas, there's an age where they stop being prescribed. And sometimes that is the end period. And for me as a dietitian, I always say we have, depending on the health system, you have to prepare for that time and therefore expand the diet, because dietary diversity is also extremely important. So I think that is also important. You both will be happy to know we've got another 10 further questions that I'm trying to get through. I'm going to move a little bit to atopic eczema or atopic dermatitis, because we've had a lot of questions through on atopic dermatitis. Of course, today's focus is really the management of cow's milk allergy. It's not on prevention. So I'm going to start, Harold. First of all, do you think in regards to the management, so a child already has got atopic dermatitis, a symbiotic or probiotic, the blends between them make a difference in terms of the management?
Yeah, well, I mean, we don't have enough data for the management of atopic dermatitis with probiotics. I mean, when we talk about the management with using probiotics, we refer to oral. I mean, oral administration.
Yes,
not topical administration.
No.
I mean, that is also something. I mean, that is a different topic in itself, but through the gut. Yeah, so I mean, we know from several clinical trials with probiotics that there seems to be, in some trials, there seems to be a beneficial effect on the flare situation, on the inflammation in the skin, but this is really not consistent so far. So, and why is it not consistent? My personal opinion is because we have not found yet the best probiotic or the best combination even of probiotics, because this is also something for the future. Although we currently available compounds and formulas are very well working quite well, there's still some room for improvement. And one mode of improving would be really to use combinations, but that is really something on the experimental scale.
And I know you. For me, that's a question I get every day. Is they already have the cow's milk allergy, atopic dermatitis. What do you actually practically then say to them? Saying, do you go for it? Because Harold gave a very, very scientific answer. But what would your suggestion be in that scenario? They already have the atopic dermatitis.
So I think it's important to be honest, because as Harold said, like we don't have evidence or which strain or which mix of probiotic has the best efficacy, and potentially could be that you would need to have like a designer, symbiotic for this person based on their, profile. So I'm always open, if the family wants to try. I do suggest a trial of a symbiotic or a prebiotic or probiotic for a limited time. I think, the cost is an issue, at least, where I practice in the US.
Yes, absolutely.
This is not something that is cheap. I mean, it's, hundreds of dollars if you really want to do it, for a long term. So that's why I'm just a little bit hesitant to have like a blanket statement. Okay, everybody should be doing this, just because not everybody can afford it. And so that's why I said, like, let's try, let's see if we see an improvement, if we see a difference, because there's such a multifactorial, and there's a condition, and there's so many confounders that, even if we make a difference, in the gut microbiota, it may not be visible. There may be no difference, in terms of symptoms. So until we have really, proven preparation, or tested in clinical trials that we can say, okay, this is working, I think there's not going to be a guideline saying, okay, you should do it. But you can try. I mean, it's safe, and it may work very well.
And I think that's the practical approach that I also take is just, and I believe that parents should be empowered to make that decision, to say, look, it's not the magic answer, and I can't recommend a specific, and we're still in that kind of phase of we're trying to establish. Sorry, you were wanting to say something, Anna.
No, I just want to also say that, I think this discussion has to include, discussion about the diet diversity and the fiber in the diet, and, just really,
Absolutely.
It's not a magic pill, that you just take and everything changes overnight. It's really, it's a very complex multifactorial approach.
Absolutely.
That they have to work on it.
I'm coming back because, as I said, there are questions coming in, Harold. I'm coming back to you, and that's the strain specificity. And I think that's a point, a question that has not come through. Although the question was very specifically on why did we use Bifido-Breve in this, specific mix. I think the question here is, why are we so specific about strains per se for cow's milk allergy?
Well, first of all, each strain has different effects in terms of on which cells are they working, which cytokines they modulate, which type of immune responses they alter, but also in terms of metabolic functions of the host. We tend to focus on the immune side, but we have also the metabolic side, the glucose regulation, the fatty acid regulation pathways, and so on. So each microbe has its own profile. And now comes the historical perspective, because Bifidobacteria breve was one of the very first discovered probiotics, and therefore we know Bifidobacterium breve for a very long time, and many studies have been done using this particular probiotic, not only in terms of the clinical side, but also in terms of basic science. So we feel very comfortable, we feel very safe about this probiotic, and I think this is one of the main reasons to use this one. Maybe in 10 years, in 15 years down the line, it will be completely different microbe. But currently, for today, we are here really on the safe side.
Yeah, and I think that's a really important message. I know. I mean, do you have a similar opinion to Harold on that?
Yes, I mean, when you are introducing a product like such as infant formula and hypoallergenic infant formula, you have to base your decisions on, on evidence. And this was one of the strains that was most intensively studied, and it's the safest bet. We want a safety first, and then also had immunomodulatory effect. So there's a wealth of evidence supporting the decision to include this particular organism.
Mm-hmm. And I think that's also, in general, as a dietitian, I would say that's the question I get most of the time. Can I just grab anything over the counter and, it will just fix it. It's a mix and it will just fix it. And I think that's what I always say is, you need to check if it's tested. What are you looking for? What is the strain? And what's the dose that you've got? So I think that's a really good message. So we're coming to the time where we're starting to round off, but I want to end with a question that's more for me and Anna, Harold, because I think you've had quite a couple of questions. So this question really is one related to the mixing method of the any formula that's got a symbiotic blend, and whether you still mix it at 70 degrees or do you mix it in a different way? It's a really nice and practical question.
Yeah, well, so that formula has to be mixed at room temperature. So it doesn't have to be refrigerated like some of the commercial preparations that have to be kept refrigerated, but it should be mixed at the room temperature, so below the whatever recommended, for other types of formulas, because otherwise you will just kill the bacteria.
Yeah. So I think also just from a dietetic perspective, because I know this person specifically said, is this against guidelines? So first of all, for everybody to know, WHO, and that includes UNICEF, suggest mixing of general formulas at 70 degrees. Now, if you mix this formula, it will actually kill, as Anna said. So these formulas have gone through, I have been personally involved in 2 of them going through the approval, I know only in the UK, but also in some of the European countries. So they've been extensively tested for this. So we don't recommend tap water. We still say you boil the water and you let it come down. So it's still water that has been boiled. So, and they have been exempt in those countries where they've been approved from those regulations. So just want to make that very clear. So we're now coming to the end of the webinar. I think first of all, to both Harald and Anna, I think amazing. Thank you very much. As always, extremely informative, and thank you also for your for answering all of the questions and sharing your knowledge. We appreciate that.
Thank you. That was great.